Welcome again to ICU Reach. Today I will present a case of a second-degree AV block. The patient is a 65-year-old male with a history of hypertension, diabetes mellitus, and coronary artery disease. He is status post-PCI to the RCA and LAD 9 months ago. He presented with 3-day history of generalized weakness and intermittent chest discomfort, radiating to his left arm. There was no associated symptoms such as dyspnea, syncope, nausea, or vomiting. Upon physical examination, the patient displayed bradycardia, with a heart rate of 48 beats per minute, and a blood pressure of 112/50. An electrocardiogram revealed a sinus rhythm with bradycardia and a second-degree AV block. Due to the 2:1 atrial to ventricular conduction ratio, it was not possible to distinguish between Mobitz type 1 and Mobitz type 2 from the surface EKG. There is also 1 to 1.5 mm ST segment elevation in inferior leads concerning for acute myocardial infarction. Laboratory findings showed a potassium level of 6.2, a creatinine level of 2.88, and a troponin level of 30. The patient received intravenous fluids and hyperkalemia treatment but required urgent hemodialysis. Echocardiography revealed an ejection fraction of 55 to 60%, with septal motion abnormality. Cardiac catheterization revealed no significant lesions in the left anterior descending and circumflex arteries, and a 100% occlusion with intra-stent thrombosis in the right coronary artery. The patient underwent thrombus aspiration and stent placement, with a restoration of TIMI-3 flow. He required to be intubated and placed on norepinephrine for a drop in the blood pressure and cardiogenic shock caused by his right ventricular infarct. A temporary pacemaker was initially placed, but the patient restored his normal sinus rhythm after the revascularization and correction of hyperkalemia, eliminating the need for a permanent pacemaker. He recovered over the next 3 days and was weaned off the vasopressors and was extubated. Unstable patients with Mobitz type 2 AV block should be managed with temporary cardiac pacing, either transcutaneous or, if immediately available, transvenous pacing. Beta-adrenergic agonists such as dopamine can be used, if myocardial ischemia is unlikely. Once unstable patients have been stabilized, reversible causes of Mobitz type 2 second-degree AV block such as myocardial ischemia, increased vagal tone, hypothyroidism, hyperkalemia, and drugs that depress conduction should be addressed prior to determining whether implantation of a permanent pacemaker is required. Thanks for watching. Please visit www.icureach.com for more educational resources.